Welcome to today's webinar brought to you by DISA Global Solutions. DISA Global Solutions is a provider of workplace safety and compliance services with more than 30 years of experience. Every year, DISA helps thousands of companies make more informed staffing decisions by offering a broad array of industry-leading screening and compliance services. With DISA, you can maintain a strong DOT compliance program while keeping your focus on the rest of your business. As part of your comprehensive compliance services, DISA will not only supply you with official regulatory agency policies, but will help you complete and manage them too. Today's presenters are brought to you from DISA Global Solutions and Current Consulting Group, and will be presenting on the topic of medication and workplace safety, DOT requirements, and best practices for employers. Today's presenters are David Eades from DISA Global Solutions. He is the Vice President of Operations for DISA Global Solutions with 20 years of experience within the drug testing arena. Throughout his career, he has made a difference implementing procedures and streamlining processes. David's professional experience includes serving as Vice President of Occupational Health Services at Sterling Talent Solution, Vice President of Drug Testing Operations at ChoicePoint, and CEO and founder of Drug Free Incorporated. With us also today is Dr. Donna Smith. Dr. Donna Smith is one of the principal authors and architects of the regulations for U.S. military, federal employees, and U.S. Department of Transportation drug and alcohol testing programs. With 35 years of experience and expertise in drug-free workplace program regulatory compliance, she is a nationally recognized expert in the areas of federal drug testing regulations, drug and alcohol testing procedures, drug and alcohol abuse awareness, training for employees and managers, medical review officer procedures, drug-free workplace policy and procedures, and substance abuse prevention and rehabilitation. And it will now be our pleasure to hear from David Eades.
Good afternoon, and welcome to the webinar. I'm really excited. I'm excited about this topic and to share it with all our DISA clients and other folks. This topic is exciting to me because although for years we've been doing screening through DISA and different screening and our drug testing and our backgrounds, one of the issues that's always come up that people have seemed confused about is the employees taking medications. It's a legal medication, but it's unsafe for them to be taking it at work. Does it make it? How do we protect the workplace? How do we protect the employee? And as it gets even more confusing as we look at the providers involved sometimes in one of these cases where you have an applicant that is taking a medication that his physicians has given him, or an employee that his physician's given him, that really doesn't know what kind of work he does, and he thinks it's the best stuff for the patient, and then we find out that the patient is doing something very safety sensitive and it has side effects that may affect his work. It may show up on a test and an MRO says, oh, this is a legal medication, but you shouldn't be working with it. And now we've got to go back to the personal physician. As an employer, I don't know exactly what to do. And these type of situations comes up a lot. And so we put together, and Donna, with all her expertise, Dr. Smith, has put together a lot of what I think is good information that hopefully that you will take away to help prepare your company and to not only for a safer workplace, but a better way to inform your employees of what they can work with as far as medications, what they can't. And so it's a much easier process as we go forward. So as you'll see, just to go over the topics, with the current issues of medication use, misuse, and abuse, our employer policy definitions that hopefully that you can use. We're also going to go over the regulatory framework on medication and the MRO and medication. The MRO can't tell doses and this type of thing from the urine specimen. So, but what is the MRO? We'll go over that. The employer actions when medication safety issue is disclosed, and information resources for employers and employees. And with that, I'm going to turn this over to Dr. Smith, and listen along with you all.
What else I'm hoping that you'll have by the end of the hour, and that is to have some up to the minute and kind of up to the date data on the extent of medication misuse, abuse, and other problems that impact the workplace. Certainly, the whole issue of the opioid or opiate epidemic, the crisis in the United States, is something that that absolutely affects where workplaces are today and what employers are having to take a look at to do their part in protecting their resources, which are their employees, their products, their facilities, and their business outcomes. So hopefully I'll also provide a framework for the development of a workplace policy on medication use that would withstand legal challenges, that would, to the optimal extent, be able to mitigate an employer's risks associated with the issue of medication abuse, medication misuse, as well as David mentioned, being sure that we protect the confidentiality, the privacy, all of the things associated with medication use by our employees relative to such things as HIPAA, the ADA, et cetera. Thirdly, I'll look at the DOT regulatory framework impacting medication use by safety-sensitive employees in the transportation industries. And the reason I'm going to do that is because that often is the standard that workplaces in general can point to in terms of why they are implementing a particular policy, particular procedures, and particular enforcement mechanisms. And lastly, I'd like to provide some information that's related to the employer's responsibilities with regard to the balance of mitigating their safety risk. Just, again, in terms of review, and much of this you have probably read in the popular press and other places, but both the National Transportation Safety Board, the Office of National Drug Control Policy, and the Substance Abuse and Mental Health Services Administration and other government agencies have been able to accumulate data over the past 5 years that indicates that the abuse and the misuse of prescription controlled substance medications, these would be the narcotic painkillers, the benzodiazepine, anti-anxiety medications, amphetamine and methamphetamine-based medications, which are prescribed for a variety of sleep disorders, of attention deficit disorders, etc., that actually the abuse of those kinds of medications, the misuse of them, or the use of them for their not intended medical purposes is actually more prevalent among the U.S. population today than is the use of what we consider illicit drugs, ranging from cocaine to marijuana to hallucinogenic drugs, etc. And there has certainly been a dramatic increase in the past decade, and I'll show you some of that data, in the use of medications for chronic pain, for anxiety, sleep disorders, etc. Now, the abuse and the misuse of prescribed medication, as to distinguish it from the use, the lawful and medically appropriate use of prescribed medications, takes several forms. It may be using a controlled substance medication, such as a painkiller, longer than it's medically indicated. In other words, the degree of acute pain or the degree of perhaps post-surgical is not any longer an issue, but the person continues to use the medication. Using it in higher doses than has been recommended, so that no longer do I can't get to sleep if I just take the 10 milligrams. I'll go ahead and double that or triple that so that I can sleep, or so that I can feel relaxed, or so that I can impact and reduce my pain. Also, use in combination with other drugs and over-the-counter medications. And probably, again, the greatest culprit here is that people that take psychotropic medications, controlled substance medications, in combination with alcohol. and then the response the body's response to the alcohol and to the prescribed medications is a synergistic effect, and so there is a greater opportunity really for impairment and for adverse effects to be seen. And the last one is that use when performing tasks that are contraindicated. So I'm sure that most of you are aware that almost all controlled substance prescription medications have a warning label on there somewhere that says that it may cause mental cloudiness, it may cause fatigue, it may cause drowsiness, it may cause this. And many of them specifically say, for example, that you shouldn't operate machinery or you shouldn't drive while prescribed this medication or while taking this medication. But frequently people do not adhere to that. And so even though that is what has been indicated for taking the medication, they end up performing tasks that are contraindicated by the medication. So this just gives you an example of the extent of the problem that I was talking about that extends back now probably close to a decade. You see the percent increases in prescriptions that have been filled or dispensed over the past 10 years. So taking a look at, wow, why did methadone go up over 800%? Well, one thing was a change really in the FDA approval of that drug to treat different conditions in a different delivery system than had been the case prior to 2010. And so now methadone, which used to be used almost exclusively to treat heroin and other opiate addiction in a liquid form where people went to a methadone clinic daily or a prescribed number of times per week, took their medication in front of the clinic staff. Now it is in a pill form, and it is now approved for being prescribed for mild to moderate chronic pain. And so again, we see a much greater prevalence of that medication being prescribed. Amphetamines have gone up over 500%. Why is that? Well, it is because of the development of amphetamine pharmaceuticals that are specifically targeted to treat things like adult attention deficit disorder, sleep apnea or other sleep disorders. They're also used rather extensively still in weight reduction programs. They're also prescribed for a variety of different neuropathic or neurological conditions. So we've seen a big increase in amphetamine medications as a prescribed medication for use on a chronic or long-term basis. Fentanyl, which used to be only available really as an anesthetic in a hospital setting, but now has been approved for use to be taken for moderate to severe pain in a patch form as well as in other types of delivery systems. So you can just go all the way down the list, and there you see oxycodone, which are probably, in terms of a particular formulation of it called OxyContin, has been one of the chief concerns with regard to the opioid and opiate addiction and opiate crisis. Clonazepam and alprazolam are now the most frequently prescribed benzodiazepines. Temazepam, lorazepam, and diazepam are also anti-anxiety medications, tranquilizers, etc. So you can see how, again, the use of those has continued to escalate from a standpoint of them being prescribed. We have become a nation, quite frankly, of if there's something wrong, there's got to be a pill that can be prescribed to abate or to ameliorate the symptoms or the circumstances that the presenting complaint of the patient. Hydrocodone, you see up there with the Vicodins and the other formulations of hydrocodone. Again, a large jump in the number of hydrocodone prescriptions that have been dispensed within the past decade. This slide is what I call the, quote, friends and family plan. When you're taking a look at when we had this data I was talking about from SAMHSA and from the Office of National Drug Control Policy that indicated that the number of people who answered on those self-report surveys that they were using prescription meds to get high or to relax or for reasons other than a specific medical reason, where did they get those pills? Were they getting them from their doctors? Were they going to pill mills? Where were they getting the meds? And the surprising thing, I guess, to a lot of us was that the responses to those questions showed that they were getting them from friends and relatives. They weren't going around and doctor shopping. They weren't buying them from street dealers, from drug dealers on the street. But over half of them said that where I get my drugs, my supply of drugs, is from friends and family. And you can see that on this slide that some they are given by friends and family. In other circumstances, another 15% of them either bought them from friends or family, or they took them. They stole them from friends and family's medicine chests, their homes, or wherever it may be. And you can see again on looking at where did the friend or the relative from whom the individuals got these or took them or sold them, where were they getting their supply of meds? And you can see overwhelmingly that they were getting them from one doctor. And I mean, I have had people tell me that they go back to their doctor and get their hydrocodone prescription, for example, or the oxycodone prescription filled, even though they really do not need it anymore and they're not using it, but it is for a friend who has been cut off from their prescription for oxycodone and who is addicted to the medication. So it becomes a further enabling circumstance. So what are the current issues then that are facing employers, as well as certainly they're facing our nation from a public policy standpoint? It is the dramatic increase in the use of controlled substance medications to treat for the variety of conditions that we've already mentioned. We do have an opioid and opiate epidemic that has reached crisis proportion in the United States, not only from deaths from overdoses, but from the cost to society in terms of people that are no longer able to work, they aren't employed, etc. So both Department of Health and Human Services and the Department of Transportation recently expanded federal drug testing programs in 2018 to include these semi-synthetic opioid drugs as a deterrent and a fitness for duty detection tool for employers. Both the federal government who has mandatory drug testing of about 1.9 million federal employees in testing designated positions, and of course the Department of Transportation regulations, which impacts over 9 million people who work in transportation in the public and the private sector of our economy. So there are literally hundreds of new drugs that are on the market every year that have potential impairing effects. I think that one of the things that certainly has changed in the past 20 years is how we have ads on television for every kind of medication that is imaginable, and you can see that here, this is what this medication is going to do for you if you have this kind of pain, if you have this kind of anxiety, if you have this kind of depression. And then across the bottom is scrolled, all of these potential adverse or and other side effects from the use of medication. And so there's really, in the pharmacological standpoint, everything seems to have an upside and a downside. Medication interactions are often unknown, and they're not monitored because people get multiple medications, oftentimes from several physicians. And as an aging population, and even in the workforce, in terms of as the workforce population ages, we know that that people are being prescribed more and more drugs. And painkillers, tranquilizers, sleep aids, readily available via the internet, as well as through walk-in clinics. And so it is no longer the case where the only place that the person is getting prescriptions from is from their, quote, family doctor or their primary care physician, but rather there are many other avenues available to people that they use to augment what they may be being prescribed by a primary care healthcare professional. So what I want to, as one of our other objectives and our topics, as David mentioned when we started, is that I want to take a look at giving you at least some kind of a framework regarding what you as an employer may want to consider as you look at whether you need to add to, revise, or even finally put in place a policy with regard to medication use, misuse, abuse, etc. So there are several key points, I think, in terms of taking a look at what you already have and what you may want to do to revise it, or as you consider putting something in place because you don't have anything in writing. You don't have anything that is kind of across the board for your company. So first of all is to limit the scope of medications that are being addressed to those that are controlled substances or have specific label warnings of cognitive or motor functioning impact. It will be an impossible task and not an advisable one from a standpoint of employee privacy and confidentiality to say that you have to report every single medication that you are taking. So it is important that you communicate to your employees that this is not to get a list of all medications that a person is on. That really what we need them to focus on and what we as an employer are focusing on are only those medications that have a potential for adversely impacting their ability to perform their work safely and to protect the safety of their coworkers as well as the public. And then the second thing is to limit the scope of employees to whom your medication policy applies. Now, certainly for DOT-regulated employees, you must have use of controlled substance medications and over-the-counter products that have potentially impairing effects included in your policy, because that's now mandated by the Department of Transportation Agency. And so you need to make sure that those employees know that they have got to abide by the standards with regard to medication use and disclosure in some cases that are a part of the DOT regulations that govern their positions. For non-DOT positions, you should limit medication restrictions or reporting to job positions where there are either complex cognitive task performance and or the operation of machinery, equipment, or vehicles, and where lapses, errors, or omissions present safety risks to the employee, coworkers, public, customer, etc. So basically, you're trying to look at for lack of a better term, a broad definition of a safety-sensitive work or safety-sensitive positions, so that those are ones that have complex cognitive tasks. We always think, I believe, of impairment in terms of motor skills, whether that's reflex response times, the ability to do eye-hand coordination, that sort of thing. But really, in almost all circumstances, a substance that is potentially impairing also affects cognitive abilities. So that's the thinking, the judgment, those kinds of areas should also be considered, so that someone who is making or needs to make a lot of decisions that impact safety, that impact their performance of their task, etc., even if they're not operating machinery or a vehicle, that falls into this whole definition of a safety-sensitive position, a safety-sensitive worker. The third thing is that we need to limit the scope of medication information disclosure. So you need to kind of decide up front or at some point as you're putting this together where we're going to require medication disclosure or medication information for the good of the employee, the coworkers, and the company, you need to decide to whom that medication or medical information is disclosed. Some policies a number of years ago would simply say that every employee had to report their medications to their supervisor, to their first-line supervisor. In general, that's a kind of a shaky position to take because that puts a supervisor in kind of an untenable position, to be honest with you, because they should not be expected to have the knowledge base or to know, which medications the person is telling them they should be concerned about or they need to address from a standpoint of the person's work assignments, etc. So to whom is the medication or medical information to be disclosed, and what specific information is to be shared or disclosed? And David and I will talk about this a little bit later in the context of when a medical review officer reports a medication safety concern to you as an employer. What do you do with that? To whom should that information be disclosed? And what specific kind of information is the medical review officer likely to disclose to you as the employer representative, as the employer point of contact relative to drug test result information? So some of the legal constraints, and I let me give the disclaimer here that I'm not an attorney and that DISA and presenting this presentation is not presuming to give you as an employer legal advice. What we want to, and certainly you should have your policy, and you absolutely, if you want to have it reviewed by your legal counsel, that is an appropriate measure to take. I just wanted to, for those of you that are in a position within your companies to be impacting on how your policy or its procedures or its enforcement is designed, to have some general background about HIPAA. We hear so much about HIPAA lately, and so I wanted to just to give you a brief overview here that in general, HIPAA, which of course is the Health Insurance Portability and Accountability Act, and talks about what information, medical information, can be disclosed. Those provisions in HIPAA, that it's protected healthcare information or it's protected whatever, are not applicable to medication disclosure or medication fitness for duty assessments that the employee consents to as a condition of employment. So a condition of employment is that you're going to be drug tested, and that if a medical review officer indicates that a drug test, you have provided information to that medical review officer in the context of reviewing a drug test result, if that information may be of concern with regard to your continued qualification or to the performance of safety-sensitive duties, that there is, again, that's a process that you have consented to as a condition of your employment with this company. And you've got a copy of the substance abuse policy and what your rights as well as your responsibilities are. So HIPAA does not have the same impact when it comes to the information with regard to disclosure of medications in the context of the performance of a person's task. Now, employers, however, are not able to obtain information from healthcare providers or health insurance plans without the employee's knowledge and consent. So, for example, as an employer, you cannot require, go to a pharmacy, for example, and tell them that you want a list of all the medications that the pharmacy has dispensed that were paid for in part or in whole through the company's health benefit program or through its medication benefit program. So that kind of thing you cannot do, but in the context, if you will, of a medication disclosure as part of the substance abuse policy and testing program, that is not considered protected information. Now, what about the ADA? Certainly the ADA does have an impact with regard to your employment decisions relative to hiring and relative to termination, for example. So you cannot categorically refuse to hire or terminate an employee based on a medication or a medical condition unless that individual fails to meet specific qualification standards, whether that is like state or federal qualification standards, or the individual cannot perform their essential job functions. So you can't just unilaterally say that we are going to terminate anyone who has a prescription for a synthetic opioid drug, and that is just our company policy. There were a couple of court cases a while ago where there was an attempt by an employer to do that, struck down by the courts, and so from an ADA perspective, you have to know that either it's because of not meeting medical qualification standards or because it is directly linked to essential job functions. So what are your policy options as an employer? And there's, again, you can do a combination of these things, but in general, there's kind of four approaches. You can certainly, in your policy, you can place the responsibility on employees to report and determine their own ability to safely perform their duties while using medication. So you can have a policy that simply says that it is an expectation that when an employee is prescribed controlled substance medications that carry a warning label about the performance of cognitive or motor coordination, motor skill activities, that it is their responsibility to attest that they believe that by taking the medications, they are able to safely perform their duties while using those medications. Now, there's obvious problems with that. Most of us are not very good judges, quite frankly, of how a particular medication or something may impact us. Another approach is to require authorization by the medical practitioners that the employee can safely perform their duties while using prescribed medications. So it goes one step further than what was there above in terms of saying, okay, whenever you're taking medications, again, you would have a narrowing of the definition of what medications, but of medications or over-the-counter products that have a warning label about the performance of cognitive and or motor functioning, motor skills, that the prescribing physician has to provide a signed statement that in his or her best judgment that you can continue to perform your essential job functions while taking this medication as prescribed. Another approach that you can take is to use a list of medications to guide employees and medical practitioners on which medications may or may not be used and those medications that must be approved for use. I know several companies that have worked very long and arduously on trying to do this, and they have kind of like I would call it a traffic signal approach. They have green medications, and so that's a list of medications that you don't have to inform anybody. These are not considered medications that would have an adverse impact. Then there's the yellow light kind of medications, and those are going to require a statement from the prescribing healthcare practitioner who has been provided with a detailed list of your essential job functions and then signs off yes or no. And then there's kind of red light, and red light medications are one that for people in certain jobs are contraindicated and therefore the assessment has to be made by a physician that the company engages to do a specific, essentially an exception policy where, yes, in this case, the use of this medication by this person for their job is okay. The problem with that approach is it's almost impossible to keep those lists updated. And it's tough because something that may be green in one dosage formulation may actually be yellow, caution, whatever, in another dosage formulation. There are also medications that it makes sense to, for the final determination to be that if that medication is always used within 8 hours of the person performing work, there would not be a safety issue, but used closer to the time. And then you get into the various formulations that exist for extended release and for non-extended release formulations. So it becomes very, very tough. And outside of employers that have pretty robust medical departments of their own that can keep up with this policy option is I think, very tough to implement. The fourth one is to have an evaluation of the employee's fitness for duty based on prescribed medications by an employer-designated physician. And if you do not have a medical department or a corporate or a company medical director, many companies have made arrangements with an occupational medicine practice, and those physicians or PAs then do medication fitness for duty examinations when the company says to an employee, in order for me to clear you to continue working in this capacity, you need to go for a medication fitness for duty evaluation. What are the policy considerations behind those approaches that I just talked about? Well, certainly the one I mentioned up front is that you need to know that employees often underreport their medications that they're using. And sometimes it's not necessarily intentional. It is simply that, they go for treatment of a particular acute episode of an illness, and they're put on X medications, and they don't even think to indicate that, oh, now I'm on this medication. Sometimes medications are changed, and employees just really are not in tune with the fact that they need to update what in terms of reporting new medications or changed medications. I mentioned about the supervisory aspect, with supervisors being the person that gets this information and that sifts or sorts this information. I think that's a risky provision in most circumstances. Prescribing physicians are often unaware of an employee's duties or unwilling to risk their patients not being able to work. So they're going to sign off on anything because they do not want they do not want to have to answer to their patient who says, Chief Doc, if you don't clear me to do this, I'm going to have to be laid off. I'm not going to have any way to support my family, etc. So the prescribing physician gets kind of caught in that vice in terms of what he or she thinks they should be doing relative to workplace safety, as opposed to what their perceived patient's needs are. It's very important, I think, that if you're going to consider a route where you're going to ask the prescribing or personal physician to be the one that does make the determination about the employee's fitness for duty to work in his or her essential tasks while taking a medication, that you do give to that physician essentially a template letter or a template form. Getting something back from the physician that says he's cleared to work is really it's not going to help you. It's not really helping the circumstance. So you should be able to make sure that the physician who's going to make that determination is provided a very detailed job description that includes all of the essential tasks of that position, and likewise that the physician then is expected to state that if the medication is taken as prescribed in his or her best medical judgment, it does not constitute a significant safety risk. And lastly, if the use of the prescribed controlled medication is identified via a drug test and the employee's prior disclosure of medications was required, you may determine a response for noncompliance. And we'll talk a little bit about that in the context of a safety concern. What are some of the other additional considerations? Certainly, looking at what the Department of Transportation has with regard to driver medical standards or the equivalent. And you can certainly, I have many companies that have simply taken the DOT driver physical qualification standards, the medication guidance there, and they've applied that to the operators of equipment, certainly people that operate things like forklifts or that operate other type of equipment. And so that becomes a kind of a standard that they can go by and that they can support. Fitness for duty examinations, we mentioned a review of the employee medication reports or personal physician statements. An annual review of employees' medications or medical history for people in safety-sensitive, safety-critical positions is something that some companies have employed with a lot of success, so that they're just like some of you are very familiar that you do an annual review of a person's driving record or an MVR, motor vehicle report. Well, this is an annual review of medications, of fitness for duty. Again, that should be limited to only those positions that you have identified and defined as safety sensitive or safety critical. Ongoing employee education and awareness efforts are very important, and certainly review of your return to work policies and practices, particularly where a person was out of work on a workers' comp injury and they are returning to work while taking prescribed medications, controlled medications, as a result of that workers' comp injury or that medical procedure, that surgery, whatever may have occurred. So that becomes a critical issue that the workers' comp doctor may clear them to come back to work, but hasn't taken into account necessarily the medications that the person needs to continue to take, whether for a long period of time or for a designated period of time, that may in fact impact whether they can return to their essential job function in a safety-sensitive position. The Federal Motor Carrier Safety Administration has for quite a while, even before they went to testing for the opioid and opiate drugs this year, has always had very specific published criteria for commercial drivers. And it's written again from a standpoint of the driver's responsibility. So prescription medication and over-the-counter drugs are allowed. However, you have to meet the following minimum standards, and that is that the medication has to be prescribed to you by a licensed physician. Can't get it on the internet, can't do whatever, has to be prescribed to you. The treating or prescribing physician has made a good faith judgment that the use of this substance is consistent with the safe performance of your duties as a commercial driver, whether that's a school bus driver, an over-the-road driver, a driver of, a driver of another type of commercial vehicle. So these kinds of things are certainly, from a standpoint of DOT regulation, they are requiring that the employee, that the driver has this responsibility. So reiterating this for, your DOT, your commercial drivers, that this is their responsibility is a very, very recommended practice. Your employer may have a policy that requires, this is what the DOT is saying to drivers, that you report your prescribed medications to them. So check with your employer. If your job function has DOT regulated medical standards, such as a truck or a bus driver, a mariner, the DOT agency will require you to report your prescribed medications. So basically what DOT has said, and what they came out with just in January too, with the testing of the opiates, they really were putting the responsibility on the employee. You have to be proactive. We're now going to test for a whole new category of narcotic painkillers. So you need to be proactive and make sure that your prescribing physician who's prescribing you that hydrocodone or has been prescribing you OxyContin for the past 2 years, that prescribing physician knows that you operate a transit vehicle or knows that you work on a gas pipeline and is going to be willing essentially to say, yeah, I'm going to continue to prescribe this. I really believe that my patients can work safely on a gas pipeline while taking this amount of hydrocodone as I have prescribed it. Getting back to what David mentioned in his brief introductory remarks, the MRO does have a role in your medication policy. And that role is because the MRO reviews laboratory positive results and determines if the laboratory result is explained by a medication that the employee has been prescribed, lawfully prescribed in his or her name, or has been a medication that has been medically administered in a medical procedure, in an emergency room or an outpatient surgery or whatever that may be. So while the test result may be reported as negative, because the MRO is required by regulation that if I have a positive test for amphetamine, and I have a prescription for Vyvanse or for Adderall that is in my name, the MRO is required to report that to the employer as a negative. The MRO's role is not to say, well, geez, I'm still going to report this as a positive because I think that the employer should know that the employee has amphetamine in their system. MRO cannot do that. And so they are going to report it as a negative. However, the medical review officer may make a safety concern determination that the continued use by me of my Vyvanse presents a significant safety risk for the employee to perform his or her work. So the MRO determination based on a urine drug test is not related to the dose used or to impairment. And that's something that we often get questions from the employer. Well, can you tell me? Yeah, she had a prescription for Adderall, but was there more amphetamine in her urine test than the 30 milligrams she was prescribed daily? In other words, was she abusing it? Was she doubling up on her prescription? Was she taking maybe 2 different types of amphetamine drugs, etc.? But we can't tell any of that. The medical review officer cannot tell that from the urine drug test result. Now, some MROs may be willing to provide medical consultation services to employers concerning the relative risks of medications reported by employees based on the job performance criteria. But this is outside and in addition to the MRO's role in reviewing and interpreting drug test results. So if there's a medical consultation or a medication consultation role that you want from the MRO, then you need to specifically identify that in an agreement and in a circumstance with your role with the medical review officer. The medication safety concern, DOT has a new prescribed protocol, and that is that the safety concern about a medication is issued by the MRO when the laboratory positive result is due to the use of a prescribed or medically administered drug. And as I mentioned before, either the MRO believes that the use of the prescribed medication, the continued use of it, poses a significant safety risk, or the MRO believes that the medication used by the employee is prohibited under DOT medical qualification standards. So, for example, if somebody who is a pilot, and there are specific medical standards with regard to medications for commercial pilots, and that pilot tests positive for amphetamine and says that his amphetamine test is because he is being prescribed Vyvanse, the medical review officer knows that a pilot cannot be flying while taking that medication. It's a prohibited medication under the medical standards for pilots. So that would be an example. The test result will be reported as negative, okay? The MRO then has to instruct the employee during that interview that they have to immediately contact his or her prescribing physician and arrange for the physician to contact the MRO to discuss the concerns about the medication. The MRO tells the donor that if the prescribing physician does not contact the MRO within 5 days of the interview, when he's talking with the donor, with the employee, the MRO is going to report the medication safety concern to the employer or to another authorized third party. Now, if the prescribing physician, in contacting the MRO, tells the MRO that he's going to discontinue the medication, he had no idea that his patient was driving a gasoline tanker truck or whatever, so he's going to discontinue that med, and instead of him being on the hydrocodone, he is going to tell him for his pain to take Aleve or ibuprofen, etc., one that does not present a significant safety risk. Then the MRO doesn't report any safety concern to the employer. He's already reported a negative test, so that's all done. If the prescribing physician says that he believes the employee can safely perform his or her duties while taking the medication, and the MRO concurs with that after discussing with the physician, again, then the MRO will not report a safety concern. But if the prescribing physician does not contact the MRO, then the MRO is going to report the safety concern after 5 days. If the donor says he's not willing to have his doctor talk to the MRO, he doesn't want to do that, then the MRO is going to report the safety concern at the same time he's reporting the negative test result. So once the conversation with the prescribing physician takes place and the MRO still believes that there is a safety concern with the medication, then the MRO immediately reports the safety concern and does not have to wait 5 days. The big difference here is that prior to the rule change on January 1, the medical review officer reported safety concerns concurrently with the negative test. Now an employer may get a negative test and have no idea, because the MRO cannot discuss it with the employer, have no idea that in 2 days, in 3 days, or in 5 days, the medical review officer is going to amend or append the negative test result with a safety concern. Go to the next slide. And I think, okay, so the verified negative drug test with a safety concern will be reported the safety concern after 5 days. What will the MRO reveal in reporting a medication safety concern? This will vary by what MRO or what MRO service you are using. There will be a general statement that the MRO believes continued performance of safety-sensitive functions by the employee using a prescribed or over-the-counter medication presents a safety risk. Some medical review officer services will give you specific information naming the medication, but not the medical condition or any other medical information that constitutes the safety risk. And some medical review officer services will provide general safety concern notice with a statement that medical professional conducting a fitness for duty evaluation or assessment may contact the MRO for more specific information. So they'll say, I have a medication concern, and tell you, the employer, that, and tell you that once you set up for a fitness for duty, medication evaluation, etc., that you will be happy to reveal, the MRO will be happy to reveal more specific information such as when the medication was prescribed, what the dosage was, all of that, but only to the medical professional who's going to be conducting the evaluation. So you as an employer then, especially for DOT results where you get a medication safety concern reported, you have to decide what you're going to do with that information. You can't just ignore it. That's entirely too great of a risk for you to take from a standpoint of your potential liability. So you are going to have to figure out as an employer what you're going to do. Are you going to remove the employee from performing safety-sensitive functions until you can resolve the medication safety concern? Are you going to have an employee sign a disclaimer stating that his prescribing healthcare practitioner is aware of all medications he or she is using and is aware of his or her job functions and has determined that the employee can safely work? There are a variety of employer responses. I want Dave to come back in here real quickly and just talk a little bit about how those of you that are using DISA University Services as your medical review officer, what you are likely to see or to obtain or to get from DISA University Services.
Yeah, at DISA, our clients will receive, as far as the DOT protocol, we follow that exactly. They will be getting a letter, a safety concern letter after 5 days if we haven't talked to, if the MRO hasn't talked to their medical provider. We follow all that, and then the client would get, if in case they don't talk to him, they would get a letter after 5 days, a safety concern letter, to recommend they be evaluated for fitness for duty by the regulations or the mode that they're regulated by. We're a little bit different on the non-DOT side. Our MRO staff believes that waiting 5 days, they continue to follow the protocol that the DOT had prior to January 1st, is that when they report the negative, we will give a safety concern letter recommending them to have a fitness for duty, or however their procedure for that fitness for duty, to follow that. With the caveat that we also heavily suggest that they call our MRO and discuss the safety concern letter. So we don't, again, on non-DOT, we do not, when the negative is reported, we do have the safety concern letter at the same time for the non-DOT. The DOT, we follow the protocol as written, and that's what we're doing in DISA now.
Even though you may be dealing with a lot of employees that are not DOT regulated, the Department of Transportation has put out some really pretty good materials that you can pirate from because they are in the public domain in terms of information for your own safety-sensitive employees. You see the first one, balancing prescription and over-the-counter programs with employee safety and health. That's an employer guide, and then a companion to that is balancing safety and medical treatment, use of prescription and over-the-counter medications for safety-sensitive employees. And so these are some good resources. There are some others on the on Substance Abuse and Mental Health Services Administration. There's also the FTA, the Federal Transit Administration, has put together a medication toolkit that has a wealth of material that can be used by employers as they are constructing medication policies and procedures, etc. So I just wanted to mention those as possible resources. So we have covered, I think, all the topics that we had hoped to do today. Certainly, the last one here, benchmark to best practices in your industry or business arena, and I think that's always a good idea. And certainly I know, and again, working with the DISA folks for a number of years, that the oil and gas energy sector of American business, of U.S. business, has in many ways been a whole leader in trying to craft specific criteria for contractors, for various kinds of workplace safety as it is connected to medication abuse and misuse, to drug use, to alcohol misuse, etc. So in the energy sector, I have often found that employers have very, very strict policies. They pay a lot of attention to it. They spend a lot of time educating their employees, and it's a condition of employment when they come to work in those environments. So that's what we had hoped to accomplish today.
Thank you, Donna, and thank you to DISA Global Solutions. We also thank all of you who have participated with us today. As we mentioned previously, if you have a question for today's presenters that you were not able to enter into the meeting, you can send us an email at the end of the presentation at transportationsales@disa.com, or you can send those messages also to info@currentconsultinggroup.com, and we will work on making sure you get those answers if you did not receive them during the presentation. If you're interested in applying for those credits, please email credit@currentconsultinggroup.com to apply for 1 credit of continuing education from HRCI, CCDAP, and 1 professional development credit is being offered from SHRM. Credit is only available for those who attended the live session in its entirety, so we thank you for your attendance. We will be emailing you out the recording to this presentation, and on behalf of DISA Global Solutions, again, we thank you for your attendance today, and this concludes today's webinar presentation.